Hello friends, I'm Dr. Mehmet Akif Öztürk. Today we will make a presentation about hyperlipidemia with you. Our presentation on hyperlipidemia is mostly aimed at medical school students. My student friends who want to get more detailed information on the subject can take advantage of the Hyperlipidemia and Management book published by the Academician Publishing House, of which I'm the editor. If you wish, let's start our presentation without wasting much time. I'm citing the flowchart of our presentation. We will first give a definition of hyperlipidemia, then we will talk about the concepts of primary and secondary protection. I will try to explain from risk groups, general risk groups, risk calculation, statins, who to treat, when to treat, what dose to treat, how long to treat, how to follow up, and other drugs used on this subject. If we define hyperlipidemia, we call it as the cholesterol values circulating in the blood, namely lipoproteins, being outside the determined optimal values. While high levels for total cholesterol, LDL cholesterol and triglycerides are abnormal values, low levels of HDL cholesterol are abnormal values. You can see the normal, low and high values in detail in the table on the side. Now, let's talk about the concepts of primary and secondary prevention. If a patient doesn't have an established cardiovascular disease yet and the risk is high, this patient has primary protection. However, if a patient has developed a condition such as myocardial infarction or a cerebrovascular accident, we now use the concept of secondary protection for the risk in this patient. Patients designated for secondary prevention are at higher risk than patients for primary prevention. Let's talk a little bit about risk. We can divide general risks into two as modifiable and unchangeable risks. Unchangeable risks are age, gender, and genetic predisposition factors, as you can all guess. Modifiable risks are smoking, dyslipidemia, hypertension, and obesity. We can reduce our risk by cessation of smoking, treatment of dyslipidemia, control of hypertension, and weight control in obesity. Let's take a look at the medium, high, and very high risk groups. If a patient's 10-year cardiovascular system risk is between 1% and 5%, when we calculate it, this patient is considered intermediate risk. If a patient has hypertension, young type 1 diabetes mellitus, or only familial cholesterolemia or chronic kidney disease, but is in a group of patients with stage 3, that is, the GFR value is between 30 and 60, or the cardiovascular system score calculated for 10 years is between 5% and between 10, is in the high risk group. However, If a patient has a previous coronary artery disease, has familial hypercholesterolemia, has type 2 diabetes mellitus, chronic kidney disease, is at stage 4 or 5, that is, if GFR is below 30, if there are recurrent cardiovascular disease under statin treatment, polyvascular disease, if they have disease, or if the 10-year cardiovascular system risk score is over 10%, they are in the very high risk group. So, how do we calculate our overall risk? Here we may have two methods used in this regard. Of these, the first score is the table we see on the left, which we call the risk table. Here we can determine the risk according to the systolic blood pressure, age, sex of the patient, and whether it's a smoker or not. Apart from this, there is a risk calculator based on the algorithm used the American Society of Cardiology. We can see it on the right. Here is the cysriskcalculator.com. We can calculate the risk by entering the amount of cholesterol and other comorbid conditions, and we can calculate the risk of getting cardiovascular system disease percentage for the next 10 years. So, what should our general approach be if we detect high risk? First of all, we need to change our lifestyle. We must adapt diet and physical activity to the lives of patients. However, if we cannot achieve the desired level of risk reduction with these, then we can now consider drug treatment. We can use statin, fibrate, ezetimibe, and PCSK9 inhibitors, which are new agents. In the follow-up, we need to evaluate the success of the treatment, its side effects, and the patient's compliance with the treatment. Let's talk about statins, an agent that we use very often in the treatment of hyperlipidemia. Statins are inhibitors of the HMG-CoH reductase enzyme involved in the conversion step from HMG-CoA to mevalonic acid. In their primary and secondary use, they are agents with proven effects in controlled randomized studies for prevention. The names of the studies on the statin groups are available, as you can see on the slide. The doses and LDL lowering rates, lipophilic or hydrophilic situation, half-life, and metabolic pathways of atorvastatin, rosuvastatin, pitavastatin, simvastatin, pravastatin, fluvastatin, and lovastatin, their effects on absorption with food, renal excretion, percentages are given in this table. As you can see here, we can see that atorvastatin and rosuvastatin are more effective than other agents in terms of LDL cholesterol reduction. I must say that rosuvastatin stands out with a half-life of 21 hours. Pitavastatin is a newer agent and has less side effects than other agents. So, who should we treat? In primary prevention, if we found cardiovascular system risk above 70.5% when we calculated the cardiovascular risk, we should give treatment to this patient. Regardless of the cardiovascular system risk, we measured LDL cholesterol in a patient, and if it was above 190, treatment should be started in this patient as well. If we have experienced a cardiovascular system event in a patient, which, as I mentioned at the beginning, falls under the concept of secondary protection, here too we need to start treatment immediately after this incident. Do you think we should treat these patients? Our first patient is a 60-year-old man with a blood pressure of 130 to 80, non-smoker. LDL was found to be 180, HDL 40, triglyceride 100, and total cholesterol 142. Looking at our other patient, a 45-year-old female patient whose blood pressure is 130 to 80, doesn't smoke, LDL, HDL, triglyceride, and total cholesterol are the same as the other patient. Yes, do you think we should treat these patients, or which ones should we treat? I will not tell you the answer to this question. You will calculate this as homework and you will find them yourself. I'm waiting for your answers to comments below. Now I will talk about moderate intensity statin therapy and high dose statin therapy. If we have a goal of reducing LDL values between 30 and 50%, we give statin therapy as a medium intensity dose here. At that point, which agents should we use more? We can use lovastatin 40 mg, atorvastatin 10 or 20 mg, simvastatin 5 or 10 mg, or pitavastatin 4 mg for this purpose. If we are aiming for a high-dose statin therapy that is a reduction of more than 50%, at that point we can use atorvastatin 40 or 80 mg or rosuvastatin 20 and 40 mg. Usually, high-dose statin therapy is used for secondary prevention. Well, we started your statin treatment, so don't patients use it for life and come to hospital? No, these patients don't need to be followed up. First of all, we call the patient after 6 or 8 weeks. We check for possible side effects and adverse reactions of statin therapy. We are looking at LDL levels. We are evaluating blood biochemistry. If we are not on the targeted LDL, then maybe we can add agents like ezetimibe, which we will talk about later. So, which of the adverse reactions do we see the most? There may be headaches, stomach aches, constipation, and muscle aches. The targeted LDL value in primary prevention should be 100 mg per deciliter or less. In secondary prevention, the target LDL upper limit is recommended as 70 mg per deciliter. These values are the values that should be considered in terms of planning additional treatment needs. The lower the lifetime LDL, the lower the cardiovascular risk. If the target LDL value is above 100, in patients with cardiovascular risk greater than 20% in primary prevention, treatment should be intensified. If there is a problem of statin tolerance, ezetimibe can be used in such patients with high cardiovascular risk. Pay attention. Transaminase elevation and creatine kinase elevation. ALT levels up to 3 times follow without discontinuance of the drug control liver enzymes after 4 and 6 weeks. Dose reduction or discontinuation of the drug is required at higher levels of more than 3 times. Intermittent dose adjustment can be considered after 4 and 6 weeks, and if it is back to normal levels, starting again. Creatine kinase elevation. If creatine kinase has increased up to 10 times, stop the treatment and plan especially renal function follow-up and creatine kinase control after 2 weeks. Asymptomatic and CK elevation not exceeding 10 times can be followed. If the CK level is symptomatic and doesn't exceed 10 times, the treatment should be stopped and the CK value returns to normal, and then low dose or intermittent dose therapy can be planned. Another question is, what should we do? A 55-year-old male patient had an obstructive cardiovascular event 2 years ago, uses atorvastatin 40 mg, and smokes. We determined the CK value as 1,200 milligrams. But the patient has no symptoms. Let's come to our other patient, a 60-year-old female patient with a history of myocardial infarction 3 years ago, normotensive, using rosuvastatin 20 milligrams and ALT level 125. The subordinate level is 40. What do you think we should do with these two patients? Should we continue the medication or stop the medication? Other drugs, fenofibrates and ezetimibe. The benefit of fenofibrates over statins has not been demonstrated in terms of the established cardiovascular disease or mortality risk in primary and secondary prevention. However, in patients with triglyceride levels above 500, fenofibrates are preferred as lipid-lowering therapy, especially in terms of increased pancreatitis risk. Ezetimibe. They block intestinal absorption of dietary cholesterol and biliary cholesterol. Used in combination and monotherapy in patients with maximally tolerated statin therapy who don't achieve target LDL cholesterol levels or who have statin intolerance and or contraindications. 10 to 18% reduction can be seen in LDL cholesterol alone. Additional 25% reduction in LDL cholesterol combined with statins. And no dose modification is required in mild hepatic and renal impairment. Now, let's look at PCSK9 inhibitors. These molecules bind to the LDL receptors on the cell surface and cause the lysis of these receptors inside the cell. Therefore, if it can bind PCSK9 with this monoclonal antibody, since the LDL receptors on the cell surface are not lysed, they bind more circulating cholesterol and can significantly lower circulating cholesterol. Basically, this is the mechanism of action. PCSK9 inhibitors are monoclonal antibodies, which are new generation agents. They have 50 to 70% additional benefit in addition to the LDL cholesterol lowering effect achieved with maximum dose statins. In secondary prevention, it can be considered in high and very high risk patients whose target LDL value cannot be achieved despite statin and ezetimibe therapy. Thank you for listening. You can contact me for any of your questions on my social media accounts. If you want to see more contents like this, you can subscribe my channel and follow me on Instagram. I'm waiting for your comments and answers of the questions that I asked. See you soon.